Hi, everyone. So just a quick introduction. So I'm Tessa, and I'm a psychosexual counselor at Hertility. So I support fertility, intimacy, and trauma recovery. I work with individuals and couples. And I'm joined by Sam. Maybe. You're muted. Yeah.
Sorry, everyone. Hi, everyone. I'm Sam. Um, yeah, I'm very excited to help talk about this topic. I think, we've had such a nice time engaging around this. And yeah, it's been awesome. And I think hopefully there can be some nice takeaways for everyone to understand a little bit about what physio can offer and psychosexual therapy, and how we work together and how we can help everyone.
So today we're going to keep it quite simple. We're going to do a rundown of symptoms, what you should look for if you're concerned. We'll kind of go over the causes, both psychological and physiological, and then our how we both would deal with solutions and treatments for dealing with this. Um, Hopefully we'll have a Q&A at the end. So we're just sort of asking that if you have any questions as we go, if you can just put them in the chat, and then we'll make time at the end to answer anything that's sort of left wanting at that point. So hope that all makes sense. And I do hope we get the chat working if it's not already. So I'm actually going to pass on to Sam to start sort of going over symptoms.
So we had a little look at some studies that have been done on pain with sex, and there's not, like you can imagine, there's not a lot. But there was one study that was done in the USA, which was quite a small sample size, which found that 8 to 21% of women reported having painful sex. And then there was a study done in Iran, which was many more people. It was about 300 women, which reported that 54.5% of women reported having pain during sex. And I think we don't have to give too much thought to those numbers because they are such different numbers. But I think what we've kind of taken from that is just that there are probably a lot more women who are experiencing painful sex who aren't reporting it, who feel like there's not the accessibility and understanding from healthcare professionals to treat it and to really acknowledge the symptoms and what we can do about it. And so there's not a lot of research, but the research that has been done hasn't really correlated with other studies that have happened. And then when we're talking about pain with sex and how to know when your symptoms are ones that can be treated or can be helped, we both agreed on the kind of symptoms which are ones that if you feel you should, if you notice them, you should try and seek out psychotherapy and pelvic health physio, which is amazing because it's just something that we really completely agree on. So if you're having pain with penetration, which can be on initial penetration or sustained penetration, or pain that isn't alleviated by changing positions, because there can be physiological changes or physiological differences between women's bodies that will make certain positions more uncomfortable for some people than others. But if that pain is sustained throughout different positions, then it's a really good indication that getting a proper assessment and some treatment could help with that. And then in the same vein, having discomfort with inserting a tampon or with having a pelvic medical exam, if you've gone to the gynecologist and you find having a pap smear really uncomfortable, or having a pelvic floor assessment. And then if you notice any any bladder or bowel abnormalities, so if you have any leaking or you aren't able to get to the loo on time, or you feel like the frequency that you're using the loo has changed completely, basically any big changes that have happened in your bladder, bowel, or sexual function. And I think we also completely agree that these things aren't openly spoken about. I think we're speaking about them more and more, but if there's anything that you've noticed, all the physios that are 10, and I'm sure Tess agrees that all the psychosexual therapists at Hertility would be very happy to have a conversation about any symptoms you think could be related to that. And then we can advise you on if we think an assessment's a good idea or not, because there's not enough accessible information about this stuff, and we really want to try and help improve that. And so on that topic, Tess is going to give you a little bit more information about the myths that there are around the subject.
Yeah. So I think we all sort of think it's normal that we ourselves, when we're pregnant, if we laugh too hard or after having a baby, our pelvic health will never really recover, and we should just live with that. Lots of women make jokes about it. It's just sort of accepted as normal. It's not. It's definitely something you should get looked at and investigated. The same with the idea that it's normal for sex to be painful. I'm hoping this is changing, but when I was growing up, I was told as a girl that my first time would be painful and to expect that we should just expect pain when we're having sex. And that's not nothing, it's nothing we have to investigate, look at, just expect it to be painful and go with it, which is also not normal. But these myths lead to people not seeking out help. Um, the other thing that both me and Sam think is really important is that not any women's health specialist is able to help you with this. It's completely okay, and you should ask any medical practitioner what their qualifications are, what their experience is, and make sure that it actually are actually qualified to help you. So with physio, you want someone who is PGOP registered, or if they're not, they have a variety of different qualifications that overlap that will give you the support you need. If you're looking at counseling, this is a specialization within counseling. So you want someone who is a psychosexual counselor to cover this. And so that is someone who's COSRA registered, which is COSRT registered. And they also have a very specific qualification in psychosexual therapy. And you can ask about this, and it's very good to ask about this. The other thing we think is really important to talk to your practitioners about is what their treatment plan is. They should be able to provide one for you, and you should be able to make sure that's aligned with what you want, and they're saying they're helping you with what you've come for. You're the expert in your body. You know what's going on. So if the person is sort of offering a treatment you think is not something that you could work with or you're helpful with, that's not the right practitioner for you. So those are just some things to keep in mind. When we're started talking about getting help, you have a couple of different pathways you can go through. When it comes to painful sex, usually with psychosexual counseling, I will get people through the GP and the gynecologist. So they've gone to their GP because there's some pain, or they've gone for a pelvic exam and the gynecologist has noticed tension or an inability to perform the exam, and then they will get referred, if available, to a psychosexual counselor to talk to them about that. What's been actually great is because more awareness is happening, more people are actually just skipping that part and self-referring themselves to either a therapist or to a physio, which is great because more people now being seen, and we're actually understanding more how common this is and how prevalent. With the NHS, there are challenges. You are depending on a local trust having the resources of a psychosexual or a sexual health clinic, which if you're in a big city like I'm in London, you're probably going to be okay. If you're more rural, the trust might not have any availability for you. And even when you do get a referral, it's often for only 6 to 10 sessions, and wait lists can be very, very long for psychosexual counseling. For pelvic health physios, it's also a very significant wait list, unless you're post-op or critical case, in which you're pushed to the front. But that doesn't mean if you're not critical that your pain isn't real and shouldn't be treated. It just means you might have to wait longer or possibly find other resources. The only other place I find it personally in my own practice is if, as part of my assessment, I always ask if there's any pain during sex. And if it sometimes comes up and people don't even think it's a problem, they'll come in for relationship counseling. I ask about their sex life. I ask if there's pain. They're like, oh, yeah, it does hurt, but that's fine. And that's then becomes almost the most important thing of the therapy to begin with. Because again, there's this ability, this feeling that people should just have to live with it, that I'm very passionate about challenging. Similar with physio, they'll be doing a regular assessment, and then additional things become apparent during the course of that assessment. Okay, and on to Sam now about causes.
So when we're looking at the causes, we like to use this biopsychosocial model, which may be something you'd come across if you've had any physio or psychotherapy treatment before. But it basically combines all the different aspects that could be contributing to your symptoms. So if we're thinking about the biological side of things, we think about the pelvis. The pelvic floor is a ball of muscle tissue that lays inside the pelvis. And that muscle tissue is very similar to the muscle tissue we have on our outside skeletal muscles. It's made up of fast twitch muscles and slow twitch muscles. And that's how you can control things like if you need to go for a wee, you can hold in your pelvic floor quickly and stop the wee happening. Or when you sneeze, you can stop yourself from leaking when you sneeze, even though there's a big change in pressure in your abdomen, versus if you need a wee, but you can hold it in for an hour or an hour and a half when you're getting back from the airport. So the different kind of muscle fibers will work in different scenarios. When something isn't working as it should, and you have something like having pain with sex, generally what's happened is there's increased muscle tone. So the muscles of the pelvic floor have become tight and short and a little bit irritated. This is not the situation that always happens. We do sometimes see the other side of things where the muscles have become weak and lax and lengthened. But generally, with presentations of people having pain with sex, things will be short and tight and irritated, which kind of fits that picture of pain, discomfort with any kind of friction to the muscle tissue. Along with that, there's a nervous system component. So if you think about the picture, we've got someone with a short, tight pelvic floor, often feeling a lot of anxiety and stress, and all of that, the nervous system changes. They buy into that muscle tone change and can increase the cycle of pain and discomfort. So all of the negative symptoms that you might feel kind of build into a cycle of making things feel a little bit worse. And a lot of the treatment that we'll speak about later is about breaking that cycle. So that's the internal biological components. And then we also have external components. So your core, your pelvic stability system is made up of your abdominal wall, your diaphragm at the top, your back muscles and your glutes, and your pelvic floor underneath, kind of like a cylinder. So if there's weakness or irritation or tightness in one of those areas of that cylinder, it means that that cylinder isn't working properly to stabilize your pelvis. And if the outside of the pelvis isn't stabilized properly, the inside won't be stabilized properly. So we need to make sure all of those areas are working well together for the whole system to be happy and healthy. And so those, you can present for physio with a back issue, and it end up being that you have, like what Tessa was saying earlier, we speak about, do you have any pelvic floor issues? Have you had any pain with having sex? And this comes up, and those two can be very related. It's not always a case, and especially not with the pelvis, where you present with one symptom and that's causing one thing, and we fix that one thing and it gets better. There's this whole cycle of different facets that we have to be thinking about. And then on the social side, I think what we both as healthcare professionals take into account is the relationship and cultural dynamics that you present with, and the effect that those can have on the likelihood of having pain with sex. And it will also influence the way that we are treating these kind of issues. And Tessa will speak a bit more about the psychological side of things.
Yeah, thanks, Sam. So yeah, it's not always just one thing. But when I'm talking to people, we will look at things like shame and anxiety. Is there a past trauma? It could be sexual, it could be medical. I will be looking at what their sex education was like. Was it good? Was it thorough? Was it quite limited? I will also be asking a bit about how they understand how their own body works. Have they been encouraged to look at themselves? Have they been encouraged to understand sex and their bodies in it? And is there any anxiety or shame around that? There's also the socialization aspect, which is women's pain isn't always believed or taken seriously. So even if you've had a painful experience and you've gone to the GP or you've gone to the doctor, you're not always believed. And that actually then adds more shame and feeling that there's something wrong with you and that there's something broken about you, which then leads to also more anxiety, which then can lead to more pain. And the last part, which I'm going to go into more detail on the next slide with, is the brain body connection. So our pelvic floor reacts to our nervous system, and our nervous system reacts to our emotions. So it's not just like we're tightening a muscle or relaxing a muscle, we have an automatic survival response to perceived stress or danger. So if we're feeling anxious or ashamed or stressed out, our nervous system thinks we're in danger and it then tightens our muscles, which kind of looks a bit like this. So this cycle is the underlying for both the work that Sam and I do. This is what we sort of think is happening, and that we will then use both our treatment plans with this idea underneath. So there's going to be an initial trigger. There will be some pain at some point, whether it's when you're 13 years old and trying to put a tampon in, or it could be a trauma, it could be anxiety during a medical exam. Something has happened that there's an initial bit of pain in that part of your body that then leads to fear, and fear that that pain will come back. As you're more scared or anxious of that pain, your nervous system kicks in and then you get muscle tension. After you have that going on, you either make sure you're not in circumstances where you'll have that pain happen again, which actually just increases the anxiety and the catastrophizing and thinking that it's going to happen again. Or if you try and push your way through it, you have increased sensitivity and you just get more anxious and more tense as it goes on, and then you have more pain. And then we come right back to the beginning. So we have fear of pain, and then we get more increase in fear of pain, and we just go round and round and round this cycle. What's really important to think about is this is not just something you can think your way out of or just relax. It's not one of those things where you just say, oh, just calm down, just relax, you'll be fine. This is your nervous system reacting to a feeling, and it's not something your brain is actually part of that much. So you do need to really understand what's happening to start undoing it all. What lots of women think, because this is happening, that they are broken, that they're ashamed, that they never have a normal sex life, that partners are going to leave them. There's all sorts of things, or that they won't be able to have children, that even if they're able to get pregnant, they don't think they'll be able to get pregnant, but they also then believe they will not be able to have a vaginal birth if they do. So there's a lot sort of intertwined with all of this, that when I'm working with people, and I think when Sam's working with people, this is what we are looking at. So that brings us to treatment. So I think it's still me. so, um, so psychosexual counseling isn't just talking about sex. We definitely do, but that's not part of it. That's not the whole thing. I will take a big history and sort of try and understand everything around it. So there's a couple different things we work with. So we start with just understanding pain and nervous system. So I will go through that cycle that I just went through with my clients. We'll talk about when they're feeling pain, what are the thoughts that are sort of attached to that. If needed, we'll take a look at the anatomy of the pelvis and genitalia. We'll look at charts. We'll look at and just sort of see what's going on in their bodies. If a woman is open to it and feels confident enough to do it, they might have some homework between sessions to take a look and see what their genitalia looks like, what they can expect, and sort of meet that with curiosity instead of shame and anxiety. We tend to do a lot of myth busting about sex, so what's normal, and what's not normal, and what they can expect, and also about the pelvic floor, because that's doing that. Doing the myth busting is also trying to undo some of the shame. We also go into reducing fear and anxiety. So we'll talk about the thought patterns beforehand. What are the triggers? What's happening when they're thinking about having sex? What happens in their body? What are the thoughts and emotions attached to that? And we'll start trying to change the mindset around it, or start trying to notice what's happening beforehand. If there's shame around that, we'll also go through that. What are the origins? When did they start? feeling this shame about their bodies or about sex? When did they learn this about it? Is this stuff actually true? Is something we work through a lot. And if it was true at one point, is it still true? And does it actually still serve them? What's important to remember is a lot of this is actually protective. And so it could be a coping strategy, possibly from a previous trauma. And so then we have to decide if that coping strategy of tensing and avoiding is still serving you, or if it's something we have to start moving away from. And then if there's any trauma, which isn't every single person, but if there is trauma, that also needs to be processed through and worked through. And if that is the case, when we're talking about qualified practitioners, make sure you have a trauma-informed practitioner, and they should be able to talk you through what that means as well. And the final part of treatment, which is the more fun part, is rebuilding intimacy. So once we've sort of worked through the anxiety and the shame, we then try and work shifting from pain into pleasure, bringing back in desire and eroticism and what it feels like to enjoy sex. So this involves talking about what makes you feel confident, what makes you feel good in your body, what's going on when you feel that way, what are you doing, what makes you feel yourself, what turns you on, what do you think is sexy. We work through all that. We have sort of long conversations about that and how we can increase that feeling of confidence in women. I also have different techniques we'll provide. The biggest one and the most helpful one is one called sensate focused, which you do with either by yourself or with a partner. And it's about exploring your body and different pressures away from the genitalia that you can still experience pleasure in. It's a way to sort of connect more with yourself, and your body. It involves lots of baths and lighting of candles and just really spending time with yourself, exploring in a curious way. Whether you're doing it with a partner, it involves we ban sex, we ban trying sex for about 4 weeks, and it's more getting to know each other's bodies outside of genitalia and outside of penetrative sex, and what feels good and what you like and what it comes up for you and your partner during that. It's also really important to expand the definition of sex beyond penetration. Sometimes I think people think that the only real sex or the end of sex is penetrative sex, and that's just not true. There's lots of ways to feel intimate and connected and good in your body that don't involve penetration. So as we expand that definition and take some of the pressure off being able to have penetrative sex, it actually does help relax and reduce anxiety with people, so they can start feeling a lot more confident in their bodies. And that's me. So I'm going to pass over to Sam.
So our treatment principles are fairly similar we'll follow a fairly similar pattern to Tessa's. So initially we'll do a similar kind of assessment, take a history, try and understand if there was a cause, or if it was just something that developed. There's not always a identifiable cause. And then I'll speak through the anatomy of the pelvic floor and the outside pelvis, kind of like how I did earlier, because I think it's very important that there's a good understanding of the anatomy, and what tissue could be affected. I think the more you understand what's going on with the pelvis, the more we can work together through treatment and improve things. We'll also do a pelvic, lower back, hip physical assessment. So look at the kind of movement, if there's any areas of weakness or any areas of where there's less movement than there should be. And then more often than not, we'll do a pelvic floor assessment. So this is similar to a gynecological assessment, but a little bit different. And it involves firstly doing an external assessment of the genitalia, seeing if there's any contributing factors of the muscles on the outside of the pelvis, and then inserting a gloved finger was lubricated into the vagina and feeling the tension through the pelvic floor. And this assessment is very important for us to understand the tension and the tone of the muscle tissue inside the pelvic floor. But it's also an assessment that we don't ever rush, and obviously consent is at the most important thing. So if it's something that a patient doesn't feel comfortable with, then we won't do it, or we'll gradually build up to it as symptoms improve. So often with patients who have painful sex, it's something that we'll do over 3 or 4 sessions, and kind of build up to being able to do it, because it's quite an important indicator for us to understand what the pelvic floor muscle strength is like, and if it has the ability to contract and relax and be controlled. But also, we're completely able to do physio treatment without doing this assessment. So it's very much up to you, and it's a discussion that your pelvic health physio will have with you, and make sure you're completely educated and you have all the information to be able to consent or not consent to the assessment. So once we understand all the contributing factors, then we can do, if we've done a pelvic floor assessment, sometimes we'll do internal pelvic floor muscle treatment. So similar to what you would have doing physio treatment on external muscles, we do some trigger point release and some gentle massage. That's also done usually with a finger, and then we'll sometimes give some homework to do that with a wand or a vibrator to help desensitize the pelvic floor and help to try and get it to relax a little bit. And then work on any of the biomechanical issues that we found in an assessment. So if there's a little bit of pelvic instability or the core is a little bit weak, then we'll do rehab focused on those, building up those kind of areas. And then this is more often than not one of the pelvic floor issues where doing hundreds of Kegels can actually make things a lot worse. So what we generally focus on is down training the pelvic floor. So getting the pelvic floor muscles, which are often in a tight, shortened state, to try and be able to lengthen to their full range, and then working on being able to control them to contract and relax. And that's something that takes time and is something that we will help you along the way with. But that can be very helpful in regaining the control of the pelvic floor. And then kind of aligned with Tessa's approach of reintroducing intimacy, that's when you can start working on potentially using some dilators. And this, if anyone's had any kind of treatment before, dilators may be something that you've used, but it's very important, I think, to be using them when you are in a relaxed and often after being aroused kind of state, because we want the pelvic floor to try and be as relaxed as possible. And if you're stressed and anxious and you're just trying to insert a dilator, then often it can make things feel a little bit worse. So that's something that we can introduce slowly, and it does work fairly well. It's just the way we do it is very specific. It's not just something that I would say you can just do on your own with some Amazon dilators. And then generally improving the pelvic stability in the core, reintroducing things like Pilates. And yeah, I think it's just, hopefully with what I'm saying, you kind of can see how well the psychosexual therapy works with the physio, and how we come from this biomechanical, biological side of things, but improving the psychological side of things is really what we need to work together to get improvement and recovery throughout, rather than just working on one thing at a time. Tessa is going to take you through our key takeaways now.
I also want to just echo that, like, it is really helpful for me if I'm have someone who's going to a pelvic health physio, because they're understanding their own body and they're working through that on that side, and then I focus on the emotional side then more. It's just, I think we work best actually when it's a combined care over somebody. Which brings us actually to our main takeaways, which really through this, what we both really want you to know is that your pain is real and it should be taken seriously. That help is available, so you don't have to do this by yourself. There's people who are trained in this and people who are able to support you, and that help is holistic and individualized. So it's specific to you and what you're going through. So it's not a one size fits all. So you should be in dialogue with your medical practitioners when you're going through this. So yeah, I think that's that. So yeah, any questions?
We did actually receive one question, and someone is saying, can't seem to ask on Q&A, but how do practitioners accommodate sexual trauma with this internal assessment and vibrators, etc., if that's triggering?
Then you don't do it. that's not part of the treatment. If you deal with the sexual trauma first before you would ever introduce anything like vibrators or dilators in with the person, I think on my side, and I think also for you as well, Sam. Is that true?
Yeah, as soon as anyone presents with any kind of hesitation to doing any pelvic floor internal assessment, then I will take it off the cards for the moment. I think if they're doing psychosexual therapy and are working through that trauma and it's something that they want to build up to, then I'll support them along that journey. But it's definitely not something that is essential or pressurized to do at any point.
We have a couple more questions actually. Is there a way we can see on our own if our pelvic floor is too tight? Is there any telltale signs that we can feel ourselves?
So if you have the kind of things that we spoke about right in the beginning, so if you have pain with sex, either on penetration or with sustained penetration, or that it lasts throughout different positions, then it's indicated that there might be some tension, as well as or that that could be completely fine. You might have a bit of leaking or feel like you can't control your bladder or your bowels as well as you should. But I think if it's these things are more difficult to just give clear answers than if your knee's sore, go to the physio. So I would say if it's something that you're thinking about, then book in for a call and we can speak about it in a very nice, open, safe, just one-to-one basis. And then one of the physios can advise you on if it's the right path to follow or not.
Yeah. Next question is, I have a partner and we have sex, which is fine. Once he's inside, easiest to get in if we sideways in a missionary style position, but always getting it in gives sharp pains and I make him push through it, but I need to use a vibrator to do so. What are some ways that we can stop this from happening? To clarify, once it's inside, we are fine, but some position like doggy less, so unless fully relaxed. I've tried numbing creams prescribed and dilation, but none of them are working for me, and I don't have the patience to go through the dilations process as I find it a bit weird, to be really honest. Is there anything else I can do?
I think I don't think a dilator would necessarily be the answer there. I would say book a physio assessment because obviously it's very difficult to give advice without any kind of full assessment. But if it's feeling like once you relax, it's much more comfortable, then it's likely that the muscles around the entrance are tight, and maybe spending a bit more time before penetration on trying to create arousal and relax the muscle tissue will help a little bit. Do you think so? Do you agree there, Tessa?
Yeah, I agree. It almost, yeah. Again, I would want an assessment to like ask a few more questions about this, but it sounds like the initial. So I would, if you're my client, I'd actually talk about more foreplay, making sure you're fully relaxed, maybe an orgasm or two before you get to full penetration, just to see if that helps. Um, and then maybe talk a bit more about what's going on for you beforehand as well. Yeah. So if there's, again, do you expect it now to be tight the first time, the first penetration, and then is that something we can start undoing? But yeah, this would involve a lot more conversation than a simple clear-cut answer. Yeah.
Yeah, I think this is something like that kind of fits with the question earlier. I would say that this is a clear symptom of you would benefit from having an assessment and doing treatment. And yes, the symptom's not causing you to be unable to have sex, but it's a symptom that you're getting every time you have sex. And so doing treatment should help. And if you don't, then there's potential that things might get worse over time. So I think it's something to treat rather than just push through.
We have a few more questions, all very interesting ones. The next one is, does Botox work for this? I've seen it as a suggestion to help with painful sex.
I've not heard that. That's new to me. Yeah.
Yeah, it's something I don't think I don't know if there've been any studies done on it, but I think if they have, there's very few. It's something I've come across once or twice. And the people that I've seen who've had it, it did help. But I think it would be good to understand the reasoning why Botox has been given, because for me it hasn't been clarified as to why it has, because the Botox stops the muscle from working. And so my worry would be that other muscles around the area might become more tense. But this is not, it's not our scope of practice. So I think the only time we'll see people who've had it is once they've had it, as opposed to being something that we advise. So I don't think we can give the right kind of answer there, but it's not something I've seen regularly at all. I think it's either a very new thing or a very niche area that only a few doctors will do.
Next question is, what is the best way to go about getting a referral of self-referring?
So self-referral, you can come through Hertility. You can come just talk to me there is one way. And if you're going for psychosexual counseling, there's lots of private practitioners as well who you can just go to. But yeah, if you just go to your GP and say you would like a referral to psychosexual counseling, or to a pelvic health physio, they should refer you. And how about you, Sam?
So for us, we just work privately. So you can either just self-refer straight for a pelvic health physio assessment. And of the 10 clinics that 10 works at, there's a physio in a pelvic health physio in almost all of them. And you can either just refer straight for a 1-hour assessment, or if you're not 100% sure if you need it or if you're presenting with the right kind of things, then you can book in for a 20-minute call, and then one of us will call you and speak to you about your symptoms and advise you on what we think the best approach is.
Thank you. Next question is, does having sex regularly make sex less painful and not tight over time?
Nope. Not that I'm aware of. It's a muscle. It's not something that gets stretched out or relaxed the more you do it, at least in my experience. How about you, Sam?
Yeah, I think we have to think, if we think back to the circle we were talking about earlier, if you're just reinforcing that pain, muscle tension cycle of things, it's not going to just suddenly come out of that cycle. You'll just keep reinforcing that.
Yeah.
Is there any research around increased sexual activity impacting bladder sensitivity?
Not that I've seen.
No, I also don't think I've seen anything.
And then we have a few questions about practical exercises. And I feel some of this question can be answered with the guide that we created. I'm going to ask them all in a row. Post C-section, how can your pelvic area recover and get stronger? What exercises can I do to prepare my pelvic floor for vaginal birth? And what exercises can I do daily to reduce or prevent leaking caused by weak bladder or pelvic floor?
So all of those would have a slightly different rehab focus. Prenatally, I would say come for a prenatal physio assessment. The physio does a assessment, kind of like what we were speaking about earlier, and then we'll give you individualized rehab to help prepare you for delivery, and then give you advice on what you can do afterwards. And then generally what we'll do is we'll do a postnatal physio assessment at about 6 to 8 weeks after you've seen your GP. And we'll do a similar kind of assessment, assess the core, the pelvis, do some education on the impact of pregnancy on your anatomy and biomechanics, and then figure out where the biomechanical issues are and what muscle tissue has been most affected. And then we'll work on a plan to rebuild all of that. You come for a pre or postnatal assessment, generally we'll do a pelvic floor assessment if it's something you'd like to do as well. And then similar for C-section, there's specific kind of exercises that we'd want you to do at different stages postnatally, but also it's very important to have the C-section scar assessed. Our physios will give you some scar massage work to do, but it's not really like a one size fits all rehab plan for all of those things. We'll have to do an assessment and then give you individualized care. I think what's really important about pregnancy is that when you're pregnant, the abdominal muscles stretch and they aren't able to contract and relax as well as they should because they're holding your baby. And the same happens to the pelvic floor. It's not able to contract and relax completely. So then after you've delivered, whatever kind of delivery you've had, you have weakness through the abdominal tissue, through the pelvic floor. And if that's not rehabilitated and rebuilt specifically to those muscles, then you'll just compensate with using other muscles to stabilize your core. And that, if it's not corrected, if you don't have treatment postnatally, it can increase the risk of like lower back issues or pelvic floor issues. So that's a really important time, I would say, to get a physio assessment and then to have an individualized rehab plan for you.
Thanks, Sam. And would physio help if you were diagnosed with adenomyosis?
Yes. I think it's one of the areas that, like pain with having sex, it's not so commercialized that physio can help with it. But definitely there's some like pain relief treatment that we can do and give you some rehab to do the same kind of thing of building strength through the pelvis and the core. And if there's any specific pelvic floor symptoms like tension through the pelvic floor, we can do treatment on that specifically. But yeah, definitely.
We have a couple of questions that, all relate to the same topic. Are there any exercises we can do at home to untighten entrance muscle to the vagina to make it looser and less tight for sex?
Yeah, but now I'm just going to sound like I'm saying the same thing to answer all the questions. Like with doing, there's like with me saying earlier, doing hundreds of Kegels might make something feel worse. It's the same thing if you're just trying to stretch and relax the pelvic floor. If it doesn't need that, it's not necessarily going to help with what you want the outcome to be. So having a professional assess and understand exactly what's going on in your pelvic floor, and then them advising you to do which exercises, and then also making sure you do them completely right. So a lot of the reason we do a pelvic floor assessment is to test that you're doing the pelvic floor exercises correctly, because people will come and see us and they'll say, I've been doing pelvic floor exercises for the last 10 years, but I'm still having a lot of leaking. But then when you do a pelvic floor assessment, they're not actually engaging the right muscles, they're using other muscles. And so re-educating on how to use the muscles is an imperative part of treatment. And if you don't do that, it's not going to change anything. So it's too individualized to give, I think, general advice with that. So.
Thank you. So silly question, but I've heard clenching your vagina is good for pelvic health. Is it true or false?
Well, yeah, it depends. It's good if you need to build the strength in it, but if you need to learn how to relax and control the pelvic floor, then it's not good. And also, if you're not doing the right thing, then it's not going to do anything, or it's going to make things worse. So yeah, it's very dependent.
So yeah, how we can help. So this webinar, as I mentioned at the beginning, is part of a partnership between Hertility and Penn Health about pelvic health. And so there are different ways we can help you. Counseling, as Tasha mentioned, and that's why she's our expert today for this webinar. And you can book a consultation directly with her by using our website at hertilityhealth.com. But also for the occasion of this partnership, we are running two offers, one as Hertility and one on telehealth, and Robin will probably cover that part. But until in the end of the month, we are offering £20 off our advanced test. So this test can really help you to get the root of some of your symptoms, such as irregular periods, pelvic pain, heavy periods, fatigue, and struggling to conceive. It gives you insight into your egg count and can screen for up to 18 gynecological conditions, such as PMOS or endometriosis in as little as 6 days. So if you feel like our test could benefit you or give you some of the clarity that you need, you can scan the QR code the discount code is directly embedded, or it's also no more pain 20. And yes, as I said, it's live until the end of the month.
Amazing. Thanks, Caroline. I just wanted to quickly jump on and say a big thank you to not only the speakers, but all of you for taking your time out on a Wednesday evening to be with us. Whether you're curious, looking to learn something new, or just simply wanting to better understand your health, we're really grateful you've taken the time to be with us. Yeah, as Caro kind of said earlier, just to echo it, we've partnered because we share passion empowering people with kind of trusted, expert-led information, and together we created the Balance Foundation, which I popped in the chat box. If you guys haven't downloaded it yet, you can download it and read about it. It's kind of like a practical guide kind of to encourage more open conversations and kind of give and empower people to have the tools to take into their daily life. So all those people attendees who are asking about kind of some movements they can do at home, we've included some kind of relaxing pelvic floor kind of exercises, some strengthening, and then some post kind of natal exercises as well to begin the strengthening of the pelvic floor. So that might be a practical guide for you guys to download. Yeah, as Caroline said, we have a special offer for everyone on the call today, which is 3 classes for £39. So you can scan this code, and you'll also be emailed following this webinar with kind of a link to avail of this offer. Also, Sam is one of our amazing pelvic health physiotherapists and specialists. So if you'd like to kind of book an assessment or treatment plan, we can also include that in a follow-up email for you as well. But we have some great women's health specialists as well. Even if that's that 20-minute phone call and assessment, just to understand a bit more, then give us a call.
Great. Thank you so much, everyone. Thank you, Sam and Tessa, for respecting the timing. We are perfectly on time. Well done. And thank you, Robin. Have a lovely evening, everyone.
Thank you.
Bye. Thank you.
Thanks, guys.